was in the Ithaca area for a few years, but thanks to our virtual technology here, I can be right alongside like nothing ever happened. So we're talking about runner's knee, or patellofemoral pain is the medical diagnosis, kneecap pain, whatever else you want to call it. I'm a runner, a physical therapist, running coach, strength coach. That's most of what I spend my time on, I'd say. I do not have any conflicts of interest, although this slide will stand until I finally do. So your classic objectives for a presentation on injuries with some medical jargon in here is basically, we're going to talk about why we get this type of knee pain, talk about solutions, and answer questions because it can be confusing. So it's important to recognize first, what is the patellofemoral joint? Because we think about the knee. The knee actually has two major joints. So the patellofemoral joint is the contact area between your kneecap and your distal thigh or your femur. So that's the area that we're going to be talking about tonight. So anything that is coming from the joint line or where the tibia and the femur meet is that would be a diagnosis outside of what we would call patellofemoral pain syndrome. So clinically, that would be things like meniscus-related pathology, major ligament tears, also the patellar tendon or patellar ligament. Any specific pathology in those realms is not patellofemoral pain. So what we actually see is that patellofemoral pain ends up being one of these diagnosis of exclusion type injuries. We have some special tests that can tell us with some degree of certainty that a meniscus or a ligament or a tendon is or is not really affected. We don't have specific tests that say, oh, this is positive for patellofemoral pain syndrome. It's usually a collection of some things that the patient has reported and some physical findings that we'll get into in a little bit. Sometimes things like pain going downstairs, pain with squatting, those things end up being characteristic of patellofemoral pain, but they're not specific to it because somebody with a meniscus tear might have pain going downstairs or pain with squatting. So it can be challenging to get this accurate diagnosis of patellofemoral pain, mainly because the standard diagnosis of it is a common musculoskeletal related condition characterized by insidious onset. So it's not traumatic. It just kind of comes on one day. And it's poorly defined pain. So we usually see it's a little bit more diffuse around the kneecap. It's rare that somebody just points their finger and says, this is the exact spot where I'm feeling my symptoms. It's usually a little bit more dull and broad, and it can kind of shift and change directions and be in different places. So it's non-specific pain around the kneecap. Why is it so common? And why did we pick this as the first specific injury presentation? Well, from 1983 to 2016, 17% of all running-related injuries that have been recorded have been patellofemoral pain syndrome, or patellofemoral pain as it's now called. So the syndrome was actually dropped a couple of years ago because they felt like they finally had enough information to stop calling it a syndrome, which is, in medicine, a syndrome is just a collection of symptoms that are associated and don't know what's going on. So now we actually do kind of know what's going on. It's still just a little non-specific because there's not one specific structure that we can point to say, oh, this is the reason why you're having your symptoms, or it's this thing over here that got really ticked off. It seems to be just a widespread joint-related pain. So why is it so common? At its simplest form, running is using your calf and using your quad. And so it's probably not surprising to find out that the two most common running-related injuries happen at the level of the knee and happen at the level of the calf. The patellofemoral joint and the patella itself is tensioned every single time the quad turns on. So your quad inserts into the quadriceps tendon, which then encompasses this patellofemoral joint, or the patella, as a bone. So the bone itself and the joint is related to muscle function. So we have different risk factor classifications for developing patellofemoral pain, much like with the development of general running related injury, where we have multiple different pathways where we can get there. it's the same type of thing with this specific pathology. There's a lot of different characteristics that can take you and get you to the same place. And oftentimes, a patient is going to have a couple of these, not specifically one category. But they're broken up into 4 major categories. So your overuse or overload without any other apparent findings as just your too much too soon type injury. Muscle performance deficits is just you weren't strong enough to meet the demands of whatever task you were doing. And oftentimes these first 2 risk factors are very much intertwined. Movement coordination deficits is basically a way to describe that the way that somebody is moving just happens to put more strain on their kneecap. And we're going to go through all of these in a second. And mobility impairments would be something's going on with your foot and or some other flexibility. This is kind of the grab bag of the categories. So for overuse or overload, we'll refer back to the envelope of function theory that Scott Dye proposed in 2005. And this was a model that was created by a surgeon who had his partner operate on his knee with only local anesthetic. So they basically wanted to map out what are the most painful structures in the knee. And the soft tissue right around the patellofemoral joint ended up being one of the more painful areas to get poked around without anesthesia. Surprisingly, a lot of the cartilage was not really that painful. The meniscus wasn't really that painful. So we think that there are certain structures that are just very densely packed with nerves in the knee. And unfortunately, surrounding the patellofemoral joint, you have a couple of them. So this model basically describes we can stress our body and we can stress the patellofemoral joint to a certain amount, and we can do it gradually over time, and it's usually fine. This envelope just represents everything that you can do and do without any issue. But if you do too much too soon, then the envelope shrinks, and now all the stuff that used to be fine and easy falls outside of that realm of what you can do. So the classic model is basically just load versus capacity, where capacity is just the amount of force that your patellofemoral joint can tolerate, and load is anything that influences that. So running, walking, negotiating, stairs, whatever it is that influences what goes into the system. And when your capacity is full and you add more load to the system, then it spills over, and that is what patellofemoral pain is. So muscle performance is something we would find in the clinic, primarily somebody who has quadriceps strength deficits. So your quad is really the key to the patellofemoral joint. And interestingly, this is the one muscle that we're pretty sure, based on the research, that weakness can then result in patellofemoral pain down the road, as opposed to some muscles like the glutes, where weak glutes don't inherently cause patellofemoral pain. They're a result of patellofemoral pain. And that's been teased out based on the designs of certain studies. But we have enough information at this point to basically say weak quads can go on to develop patellofemoral pain, but then once somebody has the pain, you start to see a lot of muscle strength deficits. So clinically, you see a lot of strength deficits when somebody comes in on day one and you're evaluating them. But the one that you're really thinking of that's more causal in origin is their quadriceps. Now, movement coordination is also usually going to be a factor, but it's important to separate out coordination from strength deficits too, because the way that somebody moves might just be a result of that's the path that they were taking because that's the movement pattern that they're familiar with, versus they're moving that way because they have strength deficits. So they are 2 different categories. If that's a little confusing, an example would basically be somebody who has a weak quadriceps running like Jep 2 on the left here. So you see the knee is going to shift in towards the midline of the body. Classically, that was thought that was a result of weak hip abductors, but more biomechanical research has teased out the knee valgus, which is the term for what that knee looks like, is more because the quadriceps doesn't have enough strength to let the knee go directly forward. So the knee is just going to bow in towards the midline of the body as a way to just save some energy. So if somebody's not strong enough to change the way that they're moving, that in my mind is not a movement coordination deficit, it's a strength deficit. If somebody has the strength that allows them to move a bunch of different ways, but their body continues to push them into the pattern that loads the patellofemoral joint more, then it's a movement coordination deficit. And so the treatment strategy would be different for those two individuals. Mobility impairments, or the foot moves a little too much and mobility grab bag. So the picture on the left here is Joshua Cheptegei's ankle from when he set the 10K world record on the track a couple weeks ago. That's actually a little bit of a misleading picture. His foot is not pronating that much actually in this photo. It's more based on the fact that he's going around a turn. The shoe is significantly slipping off the side of his foot, and the camera is kind of angled in a certain direction that makes it look like he's pronating quite a bit. But let's say he was pronating quite a bit and he developed knee pain. There is some low quality to moderate quality evidence that foot pronation can be a factor with patellofemoral pain. I would almost always think it's associated with some of the other things that we talked about, like strength deficits, movement coordination, things like that. But there is one potential treatment that we use in cases where we think, all right, the amount of motion that person's foot is going through might be a contributing factor, and we'll trial, an orthotic or something to see if that helps with their symptoms. But in isolation, it's very rarely something that's going to lead to patellofemoral pain. The other thing that falls into this category is muscle flexibility deficits of one or more major muscle groups in the leg. And the reason I don't put too much stock into that when it comes specifically to running is because running is a sport that doesn't require large end range mobility. So it's most of the time when we're running, our joints are mid to early range. There's not a lot of end range flexibility that has to happen. We much more often see flexibility related patellofemoral pain with athletes that have high range of motion demands. So sports like football and basketball, where you need to land from a jump and land deeply. Those are usually times where we see the muscle flexibility deficits as a contributing factor to the patellofemoral pain. But it's pretty rare that running has that, because most of the time running is just a cumulative load type sport. So this is a fantastic secret slide here where we're talking about the treatment strategies, which probably shouldn't surprise you that based on what we found from the risk factors, that's really the direction that the treatment goes. So a treatment-based classification in medicine is basically separating out subgroups of patients based on their findings and then treating what you found. It's very intuitive here. So what we really start off with first when it comes to running is we try to modify somebody's training load. And to me, it's let's try to keep somebody running as much as they possibly could before maybe it's not quite getting better. So we want to be helping this thing get better and move it along, but we also want to then see that they're continuing to run, because it takes a really long time to just shut running down completely, fix something, and then ramp running back up slowly and conservatively when you could still be maintaining a certain amount of running during that period. So that's what we need to figure out, and that's obviously going to be individualized to every runner. Gait retraining or modifying the way that somebody is running temporarily to allow them to run with less pain is an option that does seem to work pretty well with patellofemoral pain, and we'll get into that. Resistance training is going to be our long-term and high benefit solution, but in the short term, it doesn't work very well because it takes about 2 to 3 months to see significant muscle strength gains. So we still are doing a lot of stuff early off the bat, but this is something where we set the plan early on day one, and then we really see the effects of it 2 to 3 months down the road, and other stuff. So with these 4 treatment strategies, what we're really trying to do is educate the runner on what to expect, because these treatment strategies in isolation don't do a whole lot unless somebody has some context and some expectations. We got to develop a good client-provider relationship, or therapeutic alliance is used in medicine. And honestly, the stuff that I have over here, that's probably 50% of why the patient gets better. The other, the stuff like resistance training and gait retraining and training on modifications, you can't do that stuff unless you develop a good relationship with somebody. So that's really of most importance in all medicine, not just in a particular case like this. So we'll start with training load modifications, which are going to mean different things to different runners at different times. What we can do to modify how much somebody is training is we can change running frequency, number of times that they're running per week. We can change their running volume. We can change their running intensity. Most of the time, I'm going to point towards the issue that caused it in the first place, or that we think contributed strongly in the first place. Maybe somebody had just started doing intensity. They started doing some hill repeats. And then a couple weeks later, they developed this patellofemoral pain. The really obvious solution off the bat is, well, let's see what happens if you just run and don't do high intensity and you just do easy running for a couple weeks. And then we're also doing some other stuff here as your patellofemoral pain is calming down. And then by the time it goes away, let's see how we can reintroduce some intensity, but at a maybe slower and more gradual way that doesn't really tick off your knee. So that would basically be an example of just why something needs to be modified early on so that the knee can calm down and deal with its demands. And then as it's building up its capacity, we continue to modify their training too. And that's, again, going to be very individualized because we see runners with very different training patterns. So the gait retraining and running biomechanics, the really low-hanging fruit that we can do here is change somebody's running step rate and or running cadence. So your cadence is the number of steps that you're taking per minute. And typically what we see is with a slower cadence, you're going to see this, the runner in picture A here, they're landing a little bit further forward in front of their center of mass. So their stride length is long. There is no standard normative value for actual stride length. We just know that if somebody is quote unquote overstriding, it puts more load into the knee. And if they're landing a little closer to their center of mass, like the runner in picture C, then it's reducing the amount of load that goes into their knee. So increasing somebody's cadence by 5 to 10% is usually something that I try to do right off the bat, because it doesn't really change how much energy they have to use. So if you're only changing something a little bit like that, you don't sacrifice running efficiency or running economy, but you do see, generally you see a marked difference in somebody's symptoms as they're running. So that's something that I'll always try. Sometimes it works for people, sometimes it doesn't. If they can't keep to a beat, then that can present as a challenge, and then I'll just move on to a different solution from there. But usually running with an auditory cue and setting it to the number that you want to match to is something that has to happen early on so that somebody develops the right motor pattern. The other thing I did want to mention here is it was and still is popular in some areas to change foot strike pattern for patellofemoral pain. The reason that I don't really do that is because it functionally serves the same role as increasing somebody's cadence. When you switch to a forefoot strike, you end up just landing a little closer to your center of mass. But it comes with the downside of now you're changing the loading profile of your foot and ankle. And so in the interest of not trying to do too much too soon in a different part of the body to achieve the same result that I could achieve just by changing somebody's step rate and not having them worry about their foot strike pattern, I usually just leave that alone. So our resistance training, from a long-term standpoint, it should come as no surprise that strengthening the quads is the number one answer. Interestingly, it's not the first thing that we always do when it comes to treating patellofemoral pain, though, because while we do want to strengthen the quad early on, if we try to push the quad too hard, it's just going to continue to drive pain and symptoms in the knee itself. But there usually is some intensity level of quad strengthening that somebody can start with that doesn't continue to drive their symptoms. And so from a resistance training standpoint, the knee extension machine is probably the number one way to do that. We can officially dispel all myths of a knee extension machine being bad for you. It's never been bad for you. The machine itself is not the issue, it's dosage. And we could say that for any exercise, at any time. What do we got next here? Right, so the Bulgarian split squat or lunges or squats, also good exercises to strengthen the quads, strengthening other accessory muscles in the leg, strengthen the hip. This is our hip thrust that's weighted with a kettlebell or a barbell. It's a good best bang for your buck exercise for the hip extensors. Strengthen the hip abductors, band walks, cables, whatever you want to use. Might as well strengthen the calf while you're in there because it's the other really important muscle for running. So the point here basically is it doesn't have to be specific. There isn't one best exercise for curing patellofemoral pain. The principles of strength training are, they're principles that you work off of. So if somebody really doesn't work well in a certain exercise, then you can just sub it in for something else. There's never been a superior exercise in every way in a certain category. So that leaves us with a lot of stuff that we can do. A question that I would always get then is, what about technique? And so to dive into this a little bit, if something feels good and it looks good, then clearly you've picked it right, you got a good exercise, you dosed it well, leave it alone. If something feels bad, we're always going to change it. And changing it doesn't necessarily mean we're going to just totally jump onto the next exercise. It might mean that we cue somebody differently, or we're changing something like the weight or the number of repetitions or how fast we're doing it. So there are a lot of modifications you can make if an exercise doesn't feel right initially. And then if it just doesn't continue to feel right, you scrap it and move on to the next one because there's too many exercises to get hung up on one that you really want to try to bash your head through the wall for. And then the really tricky one is if something feels good, but it looks bad. And there are probably a lot of examples of just looking up when you're in the gym and seeing somebody do something that you think is a little suspect, but to them, it probably feels fine. In the considerations here, which are always tough, are how bad does it look? So on a scale of whatever to vomit test, that might give you the information you need to change something if you were going to change something, as well as other things like are they very experienced from a training standpoint, or are they a novice? If they're a novice in resistance training, we're probably going to be a little bit more strict and try to work on the fundamentals first before letting a lot of things slide. And then, how heavy and how many reps are they doing? Are they just picking up a pencil off the ground, or are they doing a fully loaded barbell, 10 sets of 10? So there's a time and place where if something just feels good, but it looks bad, you just let it go. And then there are other times where you'd say, no, let's actually change something about this. So this is basically my heuristic for what is good exercise technique. And then a question that I probably get after every PT session is if exercising through some amount of pain is acceptable, how much is too much? And there is no right answer to this, but the closest thing that I've come up with is the traffic light analogy of we got a 24-hour rule. And if you can't read the text on here, I can send this specific resource out to whoever wants it. But you have a 24-hour post-exercise session where you're just analyzing, did my symptoms get any worse? And in that session, what you're looking for is if something gets better, then it's your green light, keep going. If something like your symptoms are present, but they're not necessarily increasing and they are tolerable to you, then that's your yellow light, proceed with caution, and assess within that next 24 hours, did anything get worse? And if it didn't, then you're all good. And then the red light is the very obvious. This is continuing to get worse and worse as I'm exercising here. Or 24 hours later, it's still more sore after that session, even if during the session it didn't necessarily get worse. So this is a resource that I give to all patients in terms of gauging, well, was that run that I did a little bit too much for me right now? Or was that batch of exercises I did a little too much for where I'm at right now? And it's a continuously changing and adapting system too. So now on to other stuff, a very short slide where we have some low to moderate quality evidence for pain reduction when it comes to just using about a foot orthoses for a short term of like 10 to 12 weeks. They do not have to be custom. A prefabricated off-the-shelf orthotic works in the exact same fashion. So I put super feet up here because they're probably the most well-known and widely accessible hard form orthoses. So it is important. It needs to not be just something that's cushioned and flopping around. It has to have some sort of support to it that's stopping a foot from pronating inward significantly. But it's really something where we just try it. If it helps with pain, then we use it temporarily. And then once they're out of pain, we take it out and say, maybe store this in your closet if you need it someday. The same goes with taping a knee. So a hard tape, not a kinesio tape, they actually have two different, there's two different outcomes. So a kinesio tape doesn't actually do anything because it's completely stretchy. The hard form tape is enough to actually give the body some feedback that says that something is tight and pulling there. None of it changes mechanics or repositions the kneecap or does anything like that. It's purely, both of these things on the side are purely sensory. The super feet or the insoles, they'll slightly stop an inward pronating foot, but it doesn't really change the way the knee moves. So there's some non-specific sensory effect that's happening with these that just helps to reduce some pain, but they're just temporary stuff we can do if somebody is really training and they're trying to reduce pain along the way. So now we get to our prevention strategies, and it's worth noting that there are no real successful prevention trials in running related injuries as a whole. So it shouldn't be that surprising then to find out that we don't have good evidence for patellofemoral pain prevention strategies. So what I'm going to talk about is more coming from the clinical recommendations or here's my take on it side of things. This is not based on any trial or thing that we have hard evidence for. So we'll review the list that I had last time of the things that runners should do to just generally reduce injuries, which would be listen to your body, manage previous injuries, and avoid frequent training spikes, and select a sustainable training plan for you. So to me, the things that jump out most about patellofemoral pain would really fall into the avoiding frequent spikes in training, selecting a sustainable training plan category. So my prevention strategy number one would be make good decisions. And this is a very basic graph of when you make a good decision and you get either a good or bad result, or you make a bad decision and you get either a good or bad result. We've all probably been there with not even in running, but just applying this to our everyday life. But when we do think about running, we usually know if we start to feel some kind of pre-injury nagging pain that's lingering on, the good decision is probably to take it a little easier, which doesn't mean rest completely. It might just mean do a little bit less or go a little bit easier than you had previously planned to do. Because we know that running is a sport that requires consistency, longevity of training, and it's almost never worth it to just really try to crank through something and be a hero for a workout and then be sidelined to injury for some extended period of time. It's like that never really works out for people. So you can't always avoid the bad result. You can make a good decision and have a bad result, but I personally would much rather make a good decision and end up with that bad result than make the bad decision and end up with the bad result, knowing that at least I did everything I could. So the prevention strategy number one is make good training decisions. And if you don't have a training log or an actual plan, a good place to start would be make a plan. And then sometimes don't listen to that plan because you're going to listen to your body first. The other major prevention strategy, then, if somebody really wanted to try to reduce the likelihood that they might get patellofemoral pain, is focus on the quads. So if you have some extra time, building strength doesn't take that much. 2 to 3 times a week, focusing on a muscle group for 3 to 5 sets of repetitions to a certain intensity. And if somebody is well trained or has training experience, that intensity prescription might be a little bit more specific, like use a weight that you couldn't lift more than 5 or 6 repetitions of. But if somebody is just starting to get into something for the first time, we're usually going to change that prescription to something more capacity based. The reason why 3 sets of 10 or 3 to 4 sets of 10 to 12 reps is so commonly prescribed is because it's a really good place to start if you haven't done something in a while, to be hard enough to elicit some adaptations, but not so hard that you're going from 0 to 60. So it's a really good kind of middle ground, kind of hard place to start. But again, this is going to be individualized too, because everybody's coming from a different background. But what we would say from a prevention strategy standpoint is keep strong quads. Everything else kind of comes secondary to that for the purposes of patellofemoral pain. And so unfortunately, patellofemoral pain is a diagnosis that doesn't have a great outcome or prognosis a lot of the time. And so it's probably something that isn't mentioned too often or is under talked about in this area, is patellofemoral pain can become pretty chronic. And chronic in itself as a term is pretty debatable, but if somebody's had something for years, or they've had it on and off for years, or they've had multiple bouts of something in their lifetime, we would probably just label that as chronic, or they've been dealing with it for a while. My anecdote of running with patellofemoral pain is me before beard in 2010 and me after beard in 2019 is you're going to have some times where you can't stick to the plan. So you can make those good training decisions. You can not skip days in the gym, and then you can still have some bad outcomes sometimes. And so you have to use the treatment strategies that we outlined here, reassess your goals, change the situation. And then once you're kind of out of the worst of it, then you go back to training and you proceed and you keep going. And it's gonna be different for everybody. People are gonna be coming from different backgrounds, but this is not a diagnosis of you can't run anymore. This is something that is you can run through it. You can be self-limited, as it's called, and it's going to mean that sometimes you just need to reevaluate the goals, but that's okay. So what are our take-home points? Patellofemoral pain is non-specific kneecap pain. It is non-traumatic, so it'll kind of just come on insidiously, and it's somewhat of this diagnosis of exclusion. So we've ruled out a bunch of other bad stuff, and we're left with this non-specific joint pain. Our main risk factors, some combination of doing too much too soon, muscle strength deficits, movement patterns maybe, and maybe some weird foot stuff. Primary solutions based on our risk factors. So we treat what we find, and the prevention strategy is basically going to be stay strong and try to limit bad training decisions. That's the goal for everything, isn't it? So now we'll turn into our Q&A.
Oh, well, thank you, Jason. Let's see. Why don't we stop sharing screen there so everyone can see. Yeah, that was useful. It was great to see kind of the well, I mean, in this case, I think we were sometimes a little frustrated last time. It was like, okay, we know we've got general problems, but my knee hurts, or right. Whatever it is. And I mean, like, actually, I'm dealing with a little bit of nagging pain right now in my knee, but it's actually fairly specific. Like, it's only in one place. It's when I do a specific thing. It's not moving around, so doesn't quite sound like what you're talking about.
Well, and sometimes we do get some localized patellar pain, and you could probably lump that into the same category. I would say, though, the most common presentation we get would be like the more diffuse patellar pain.
Yeah. So just as a reminder, folks, if you have questions, please put them in the chat. The one thing I was remembering from your strength workouts that we did, I don't know, 2 summers ago, I guess now, was I think there was an exercise called Nordic quads. Yeah. You were kind of kneeling and leaning back, was it?
Yeah.
And basically, so your body weight is, you're kneeling down and then you're leaning back, keeping your body straight. And
yeah, it's almost like So you're kneeling on both legs, and then you're keeping your hips forward as you're bending backwards, and it's going to end up feeling like a stretch in the front of your thighs. But if you're holding weight in front of you and controlling your body backwards, it's a very isolated quad exercise. And since COVID, that's been a very hotly prescribed exercise because nobody has access to leg extension machines. Well, maybe some people do, but I certainly don't.
Yeah, so I was thinking that could be a really good one. So okay, Belinda, let's get to your question towards the end because I think it's not specific to knee stuff. Eric Sembalek, you have a question about weather. So why don't you go ahead and unmute and ask Kason.
Oh, you're still muted, Eric.
There we
There you
go. So thanks for being here. I've just noticed with mine that almost regardless of what I do with strength training, other types of training, when it's weather like today, whether it's in the spring or the fall, although I guess we could have weather like this at any month of the year, but 40s and rainy tends to just really bring out the knee pain. So is that a common thing or not?
Yeah, so from a literature standpoint, there's not a whole lot on the weather effects. It's a lot of qualitative research on weather effects and joint pain, but not anything that they've figured out from like significantly changing pressure in the joint or anything like that. Anecdotally, as a clinician, I definitely hear about it on a cold, rainy day, or the first time that it gets really cold after somebody hasn't quite acclimatized to it. So I would say personally, I also feel that. I don't know that there's a specific reason for it. There's probably a lot of psychological reasons for it, I could imagine. I know personally, I just am miserable when I go out to run in the cold rain. So I never really feel great when I'm miserable. But yeah, I'm hesitant to blame pressure changes on it because it's so insignificant of a change that it doesn't seem like it would create the type of symptoms that people do get when they're exercising in the cold. But yeah, from a literature standpoint, there's not a whole lot on it.
Well, in temperature, I mean, I wouldn't expect the temperature of the knee itself to vary very much.
No, sir. I mean, to actually change the temperature of a joint, you need like cold or hot contact on it for a long period of time. And then after 20 to 30 minutes, maybe you get a couple centimeters of depth of temperature change. Otherwise, exercising increases the temperature in the body, but again, not by such a large amount that we would think that it's significant.
Now, Eric, do you notice a difference with if you're wearing, like warm pants or tights as opposed to being in shorts?
Not really, and honestly, it's not necessarily the cold because I do fine in snowshoe season. It's this transitional stuff. So even in the spring, I dread it getting warm because it's like if it's a little bit above freezing, I don't know, maybe the moisture has some relationship. When all the moisture is frozen, it's 0, I'm fine. 70, I'm fine. So yeah, I don't think it's a pants thing, although snowshoeing creates more heat than regular running. So I don't know, but that's just one thing I've noticed. So it's just
certainly there's the historical, that talks about people, saying their arthritis acts up in the cold and wet, and so okay. Julie, you have a comment about related to indoor track workouts. Why don't you go ahead and unmute for the ask?
Yeah, so I've had various knee problems, and I don't think they really fit into the category of what you were talking about tonight. Specifically, the most recent one was called a tendonitis that was right above the knee. Mm-hmm. But it seems like every time I run into something, it's when I'm like, training for the Hartshorn. So I don't know if it's inherently just because it's more intense, or do you see because, indoor track has got tight turns, does that, play a bigger role in knee injuries?
Right. So the track stuff has been investigated to the point of it takes it takes much more than just running around a 200-meter track to see any kind of significant asymmetry at the level of the knee, the hip, basically all of the proximal joints. The only thing that we see that changes after like one season of competitive indoor track is that somebody's ankle inverters and everters get stronger, but at a different pattern. So basically the inside ankle and the outside ankle, their strength profiles change a little bit. It doesn't end up affecting injury incidents. I would definitely think that it has to do with ramping up intensity as opposed to the specific directional changes. From a quadriceps tendonitis or tendinopathy standpoint, that I would definitely say is related to increasing intensity of running, because we see load pretty significantly increases on our rectus femoris, one of the four quad muscles, as we're starting to get closer to that sprinting pace, which mile race pace is closer to sprinting pace than probably our easy training runs. Mm-hmm. So basically just kind of loading it in a different way than it had been used to. But that would be just from that information, that would be my idea.
Okay, thank you.
Mm-hmm.
So Jason, you're talking a little bit about sort of increasing training load. Is there any kind of a
rule
more
of thumb?
Than just don't do it if it hurts kind of, because like we can all get away with like a workout, right?
Yeah.
And, maybe we're sore the next day, but no big deal. But, then it's 2 weeks down the road that suddenly this knee pain or whatever starts kicking in. Is there a way to sort of feather it a little bit so we're a little less likely to do that?
Yeah, so the reason there isn't a validated 10% rule or 20% rule or any of that kind of stuff is because the runners' training experience and what they've been doing up to the point where they change something is so influential on their ability to tolerate what change they're going to go through. As a like clinically applicable, here's what I do to reintroduce intensity for runners. What I have them do is start off doing some kind of interval by going to their half marathon pace. So it's like, you're the slowest end of what a tempo run is. That's going to be the fastest that you run today. And if it went well, then we'll do it again next week. And if that went well, then you'll bump up to your 10K pace. And so that really slow, gradual progression can get somebody back to intensity pretty well. The downside is that it just takes really long. And nobody likes to do that. So the answer is basically the stuff that we want to do isn't fun, and the stuff that is fun is riskier.
Okay, well that seems fair. And I will admit, having come back from plantar fasciopathy or plantar heel pain for the last months and months and months. Yes, it just takes freaking forever. And I will say it's a little easier to do when I haven't been able to do anything else. So
right, the longer somebody's injury is too, usually the easier it is to just say, all right, you know what, I'm fine with this progression because it's better than not doing anything.
Right. Okay, if there's any other questions, Belinda, you had a question, which I don't know if it's knee related, but why don't you pop off and unmute and go ahead and ask about your bone marrow edema.
Well, it was actually knee related.
Oh, it was knee. Okay, good.
Jason, thank you so much. It's just been so informative. So I was running, and I was running really flat for like 2 hours, which I never do. I always run hills and down and trails. And afterwards, I felt on the left side of my knee, right to the left of the patella, on that bone, it felt like a bruise. And so I went to my chiropractor, and he did some things, and he said, well, you might have a little something here by the meniscus. But I went to an orthopedic, they did an x-ray, they said my knee was fine. But then come back in a couple of weeks if it stays the same. Well, it got worse and worse. So they scheduled an MRI, and then I got the MRI, and they said, now I'm 69 years old in a month, and I've been running a long time, and I've been coaching. And so, and I'm pretty attuned to my body. And I said, they came back with bone marrow edema right where the bruise was, to my point, like right under that my inner knee. Mm-hmm. And but they said your meniscus is fine, everything's fine. You just have to not run. Actually, don't walk too much. You can ride your bike and go swimming. So I actually listened to that, and I've started running as of last week, and I feel really great. Today I felt a little bit of a twinge in there, and my question is, will this come back again and again? What can I do maybe to prevent it? And you're so knowledgeable, Jason. I thought I'm going to take advantage.
Yeah. So that's definitely something that we see in certain populations of runners. It's one of the things that's tricky about it is it's hard to differentially diagnose it from a meniscus tear. And so usually an MRI is the only way to see that somebody has bone marrow edema or a bone bruise.
Yeah. So I had the MRI. So
yeah. So the way that I treat a bone bruise is actually very similar to the way I treat patellofemoral pain, because the origin of patellofemoral pain is probably closer to what like a classic bone bruise is than something like a meniscus tear where we need specific tissue healing to happen.
Right.
So what a bone bruise basically is you go back to that envelope of function slide I had, is that the bone is just not tolerating whatever the demands that are being placed on it is. So in your particular case, it was just that one run seemed to be a little bit too much given all of the context of what had happened just before it, whether it was how much you recovered before the previous run or other context. So the answer is yes, it can definitely heal, and given the right amount of progressive loading, it will heal. What's always tough to figure out is it sensitive to cumulative loads? So let's say not a lot of impact, but enough over a long period of time where it builds up and gets really sensitive, versus is it sensitive to peak loads? So something like jumping or landing hard, like running downhill would be a peak loading type activity. And the stuff that is really, really sensitizing it right now is the stuff that you probably want to stay away from, and you want to just train the things that are allowing you to train more. So whether that's cycling, whether it is even getting back to walking, things like that. And then it's figuring out a sustainable schedule of running from a return to running standpoint, which is a lot of guess and check. It's a lot of, all right, if I did a little bit today where I just kind of said, well, let's see what this feels like. And then the next day, 24 hours later, I was not sore. If it's not sore 24 hours later, then you can basically chalk that up as a win. If it is sore within that 24-hour window, and it means whatever you did was probably a little bit too much for it to be able to tolerate from a consistency standpoint. And there are times when that 24-hour rule, there's definitely exceptions to it. There's a time and place to do something that makes you a little bit more sore for greater than a day. From a sustainability and trying to progress loading standpoint, that's a really good rule of thumb that I like to use. And then I also like this rule of twos with a return to run schedule, which is if you had one successful run where you weren't sore 24 hours later, you do that exact same run a couple days later, or however many days in between, to make sure it wasn't a fluke. And then if that one was successful, then you increase it by a conservative margin. And the recommendations are always going to be different, because if somebody says, hey, I got this race on this day, then that's when you might need to be a little bit more aggressive with changing somebody's return to run schedule. But if they just want to get back to it and they don't care how long it takes, then the more conservative you are with the additional time, the better it is.
That's perfect. I'm just glad I'm able to get back and start running. And but I had never heard about that before. And but I guess I was happy to see that my knee looked good after all these years. I
mean, the score one for consistent running, because running actually seems to be protective against osteoarthritis at the level of the knee and at the level of the hip.
It's very interesting, because I have it in my hands, but I don't have it in my knees.
You don't run with your hands.
No, and I mean, that's true. Thank you. Yeah. All right. Thanks a lot, Jason. It's been great.
Yeah, you got it.
Thanks, guys.
Yeah, I was just going to say, I just saw some research about that, or even more research that they were talking about how, runners do not have problems with their knees from running.
Yeah. Yeah, we don't have like the death sentence issues with our knees. We just have like nagging, annoying pains.
Yeah, right. Eric Sambuck, you have one more question here.
Yeah, I figured why not. So I was just
go for it. Hey,
with strike and gait and leg length, or I'm sorry, with stride length. And given that, you know, you're going uphill, you're most likely going to be landing forefoot with a shorter stride. And I'm not saying all or nothing, but if you compare speed work up a hill versus speed work on the flat, is that going to be relatively better for your knee to do off?
So yeah, the interesting thing about running uphill is that it decreases impact and it increases muscular work. So if we think that something has a component of more of the impact with the ground, then you might actually be more successful with the speed work up the hill. And the one problem practically with that is that you have to get down the hill at some point. Running downhill is a lot of force at the level of the knee because it requires a lot of eccentric quad strength to be able to control the body. So that's why, I mean, if anybody has ever done a race with a lot of downhill throughout the course, your legs are just absolutely blasted the next day. And it's not just because you ran so fast. It really is, you get more muscle damage at the micro level when you're running downhill. But yeah, I would say overall, you can reach some pretty high intensities just from an internal workload standpoint by running uphill. It's just the issue of getting back down.
Well, one thing that Eric, I don't know if you've had your athletes do this at times in coaching, but you know, if you have a relatively short, steep hill, blast up it, walk down.
Yeah.
You know, I mean, no, I mean it's you know, if you're trying to work around that kind of problem, you know, there's not a lot to be gained running downhill unless people are putting some real thought into it. I'd actually like to have people practice running downhill, because I think people often run downhill very badly. And you can go faster and reduce impact. Well, if you go faster, you will reduce impact. But that's tricky. But so yeah, I think just walking down a hill can also, you know, you get a lot of that strength work on the other side.
Yeah, running downhill is tough, because you think if you have a race that is going to be very hilly, you have to train for it. You have to prepare your body for it. But there is also a certain quantity of it where you just kind of consider, is the risk in practice worth the potential reward of the performance benefit of it? You know, you can't exactly reproduce the demands with strength training and track work, but you can get pretty good at speed work and developing some of the similar physical properties. So I think that's the thing to use sparingly, and it's contextual. As like somebody who's really into middle distance running, I almost never do speed hill training, because I'm just going to run fast on a track. I don't have to go up or down.
I do mountain racing. So that's different.
Yeah, right. Eric and I have both done the race up Bristol Mountain on snowshoes.
Yikes.
Which, yeah, they advertised it as a 5K with, I don't know, 1,500 feet of climb, but unfortunately they were wrong. It was 2 miles with 1,500 feet of climb. Just horrible. All right. If we have any more questions, any final stuff? Otherwise, I think we're pretty good. This has been absolutely great, Jason. Thanks so much. And
yeah, absolutely.
We had one request for the slides, so maybe we can like dump those to PDF, and I'll post them along with the YouTube video. I think these slides will, you know, people can see them wanting to just go through them on their own a little bit more so, rather than just rewatching the whole thing.
Yeah, that works. The only there was like only a couple slides where some pictures they end up on top, but for the most part, the information will be there.
Okay, and also I think you said that red light or the yellow light, green light you have as a PDF.
Yeah, I can send that as like separate JPEG files.
Yeah, just send that to me too, and I'll post it with everything else. So
sure.
All right. Well, thanks to everyone for coming, and we will see you next time when we go in for another one of these injuries.
All right, thanks a lot, everybody.